Hello and welcome to Below the Hospital, an AAMI podcast on sterile processing and the issues that sterile processing technicians face today. I am your host, Garland-Rhea Grisby, Interim Assistant Director for Sterile Processing and Endoscope Service Manager at Kaiser Permanente. I'm also a long-standing AAMI member. I interview folks from around the industry about sterile processing and ask what some might call hard questions, but I would say informative questions about our profession. Today, I have the pleasure of speaking with none other than Alpa Patel. Alpa is Director of Scientific Improvement at Nelson Labs, a Sotera health company. She is also co-chair of AAMI's Working Group 44, Steam Sterilization Dental Practices, and has contributed to guidance documents such as ANSI AAMI ST59, ANSI AAMI ST98, and most recently drove the revision of ANSI AAMI ST58. That being said, let's talk about ST58 and its revision. Alpa, just want to start off by asking you, or by saying thank you for joining us today on this episode. And just want to ask you, for starters, what were some of the reasons for the update to ST58? And it's a two-part question. And what needs or issues does the new edition address?
Very good question. Thank you, Garland. ST58, as we all knew, was outdated. The last time it was revised was probably a decade ago, 2005. And things have updated. Regulatory requirements have updated. Healthcare has updated since that time. And SPD, department layout, workspace, flow space, lighting conditions, and requirements regarding ventilation systems and what's clean, what's not. All that visual inspection, all of monitoring systems, record keeping, all that stuff needed updating. And it was from the committee and the people in the user community where they needed an update because now they're conflicting with the IFUs that are out there that they don't have, and the systems don't help them identify those that we had current with the current document. So it was time for an update, and that's what prompted the updates to the standard.
Awesome. Definitely needed. I remember having the older version of ST58 forever, and it sat there forever. So thank you. Now, what kinds of sterilization procedures does ST58 apply to, and what modalities are covered?
So with ST58, they have a low temperature sterilization modality is what it's going to be covered. With that, there's chemical, and with that, there's also liquid chemical sterilization, right? Because those still do happen in healthcare practices with glutaraldehyde or peracetic acid or hydrogen peroxide. But with the sterilization modalities, what we have is we have vaporized hydrogen peroxide, and we also have hydrogen peroxide, peracetic acid, and ozone sterilization combination as well. But then we also have a new addition to the standard that wasn't before, and that was ethylene oxide. As you know, ST41 governed the ethylene oxide usage in healthcare practices. It was so outdated, so it was recommended by the committee to get that standard into ST58, put it under low, since it is a chemical and a low temperature sterilization modality, to add that into the standard. So we have a whole new annex, Annex S, that talks about ethylene oxide sterilization, what are the updated requirements for it, what are the monitoring requirements for it, and what are the ventilation systems that you have to have if you're going to be executing this type of sterilization at your facility.
Thank you for touching on that, because I did have a question about ethylene oxide, or ETO as folks call it, down the line. But, thank you for going there. So what are the implications that ST58 has for sterile processing, and how would implementation change day-to-day operations in sterile processing?
So with day-to-day operation with sterile processing, with adding all these new systems, you would see more record keeping. There'll be a lot more training on how to use these sterilizers, what kind of PCDs you need, and the monitoring program of the PCDs. If you do have failures on the PCD, what are the risk management strategies for that, for the day-to-day, who are they going to? So now we have a point of contact. Nice. Before it was left open for you as an SPD person to decide how you're going to move forward. But now you do have a point of contact, your infection preventionist personnel, to go and say, hey, this is what happened. What is my next steps? And they should have that that avenue for you to go through.
I love it. I love it. So going back into ETO, just a little bit more, what information on sterilization modality was included in this updated ST58 and why? I mean, you mentioned that it was outdated in the sense of it didn't harmonize with IFUs. Is there anything else?
Yes, they definitely put down that for ventilation system and exhaust systems for these sterilizers, you have to have a minimum of 10 total air exchanges per hour, right? Now that is written in there. Another thing is to look for, at least for ETO, look at EP sterilization regulations for monitoring programs, right? That has updated. What kind of monitoring programs and how long do you have to do these programs? How long do you have to keep record keeping for these have been updated as well as per EPA. There's also several emission control technologies out there. What are you doing about that for occupational health? And also with ETO, where before it allowed outside aeration of the chamber, now it is clearly written it's in chamber aeration. So your chamber now is blocked for those 12 hours or whatever the aeration is written in the IFU before you start a new cycle.
Wow. Okay, so that brings us right into this next question, right? ST58, right? It includes information on personnel management in SPD, including education, training, and certification. Could you tell us more about that? Because it seems like we have a lot of work ahead of us as far as education and re-education is concerned.
That's right. I know that from this discussion, there was a lot of discussion on competency testing and when should that be performed? Yearly, 6 months? What is the right amount of time? And I remember, I think it was APEC that talked about that. They did a study and they showed that after 6 months, if you're not doing that work for up to 6 months, you now drop on your competency level. So with them being on board, we did say that competency should be assessed in the standard at least yearly, right, for training. And also we took the language from SD59 and specified that there's certification. If you're going to work on a certain product that requires certification and in-depth, for example, flexible endoscopes, you should have a certification within 2 years of employment.
That's good. That's good. Recommending certifications for folks that are doing special tasks or specialty assignments, definitely needed. So what about the standards quality control requirements? What changes were made in this area? I know you mentioned EPA and things like that, but what changes? With
the standard, we focused on strengthening focus and quality assurance, right? That was the big thing. Who is keeping the record of biological and chemical indicator use, equipment maintenance, traceability from SPD, from point of use to SPD, what needs to be written in the form so the SPD knows what they need to do. So there is a specific requirement, and for labeling on the form, it says patient identifier, date of procedure, location, employee contact, time of point of use completed. So you know when the point of use was completed. And so that communication is actually written down in the standard that these 5 things have to be in a form when you're transporting to SPD. Another thing is manual and ultrasonic cleaning. When should the solutions be used, right? And how are you recording that? Is it after the 8-hour shift like SD79 says, or is it something different? So that is left to the healthcare facility to determine. Also, how are you monitoring your automated washers? Do you have a log? And what are you monitoring? And when is your checks? Are these machines validated? Sterilized as validated? What are your biological and chemical indicator use? And equipment maintenance and validation, basically. Biological indicators, equipment maintenance logs, staff training and competency documentation. All of that is what is probably required in the quality assurance or routine checkup. Also with detailed records on sterilization and HLD cycles.
Mm-hmm. So we do have a lot of work ahead of us. Some folks may have implemented some of these changes already in their facilities, and some may not have. So again, in our world, in our field of sterile processing and in healthcare in general, there's always changes, and it's important to keep on top of the changes that are out there so that we know exactly what we should be doing in the present. So thank you for answering that. Have you received any clarifying questions from sterile processing professionals about applying or implementing the standard that you would like to address?
The biggest questions we get is, how are we monitoring the water quality for HLD? we do get a lot of questions on water monitoring because it's not specified very clearly in SD 108. They give you guidelines, but the collection points, how are we collecting them? What are you monitoring? And what is required as what is recommended, right? So there is tons of questions on that. Also, chemical use, single use versus multiple day use. How much information or log do we need to do? Do we need to do a test strip every time we use, or can we do it once a day, or can we do it after 4 hours? The standard says every time you use, you have to have a test strip. Yeah.
So you mentioned something that I feel a lot of people get confused, and that is required versus recommended.
Yes.
You want to just go in a little bit about that, because some folks will look at standards and they say, oh, it's required, but that's not necessarily true.
That is correct. That is not necessarily true. A lot of the language in SD58 is a recommendation. So if your facility can accommodate the recommendation, then we highly recommend that you do implement that. There are some instances where there is required, right? But recommended is water, because we know we can't require right now. You have infrastructure to build to do these things. Storage of chemicals and what should be labeled on the containers, the description of content and expiration date, that's required. Testing every time you use with the test strips is required. So there is, wherever you see required in the SD58, where it impacts the chemical or impacts patient safety, we have usually used the language of required, but a lot of it does fall into recommendation and in the gray area where we've left the healthcare facility to determine, or the infection prevention is to determine what is appropriate for the facility.
Nice. Thank you for clearing that up. So you heard it, folks. There is a difference between recommended and required within the same standard. Now, does the Chemical Sterilant Hospital Practices Working Group have anything else in the works?
Yes, we do have 2 standards that we're working on currently. We have one that's TR 118, which is focused on UV disinfection in healthcare practices. And we have another TIR, which is 121, which is focused on decontamination practices for patient care devices.
Nice.
Yes.
Nice.
Yes. So we are working on those 2 under that working group currently.
Do we have an ETA? I know coming up with standards, guidelines, TIRs, and things like that is it's a robust process.
Yes.
And the wheels just keep going and going before there's a consensus on a document. Do you have any idea of when any of those will come to the fore?
With TIR 118, where the UV, we're almost done drafting the entire document. So we've already had 1 round of comments for it, and then we're definitely going to have another round of comments. So we're looking at probably late next year.
Okay.
As it comes off of TR 121 is very raw. So we just have started putting the skeleton bones together. But we know that healthcare acquired infections are more now on non-critical devices because we fixed the critical part of it. Now we're moving on to the non-critical side of the world. And so this is something, these 2 standards were recommended by the SPD community in our group.
Wow.
Because they saw the need for it, and they saw this is where there needs to be the next focus.
Awesome. See, this is exactly why we need more users, end users, as part of these groups and part of these committees, because we're on the floor. We see what's happening, and we have all of these questions and all of these ideas, and joining one of these groups is exactly how these questions come about, and how these TIRs and how these standards come about. So thank you.
Thank you.
Well, Alpa, I have nothing else. Thank you for taking the time to sit and chat with us on this episode of Below the Hospital. You're stretched thin, but thank you for taking that time out to meet with us.
No, thank you for having me on this call. I'm very, very passionate about patient safety, and I have a whole world of respect for the SPD department that does these cleaning and disinfections day in and day out. We validate them, but you do the real work, and we give you hats off. Thank you so much for doing that for our community.
Much appreciated. So, folks, as usual, I hope this episode has been useful. We'll be back in 2 weeks with another episode. If you want to support the podcast, you can find us at Below the Hospital on Spotify, Apple Podcast, YouTube, and AAMI Array. Until then, see you when I see you.